Okay. Thank you, thank you. You did it. Woo! Cindy, you always save me. I owe you. Thank you. Okay. Let's get this. Oh, come on. All right. It's 9 o'clock. Hi, everyone. Everyone sign into the chat box. We're going to keep it casual today. If you don't want your camera on, that's up to you. But we've got to get through this chapter, and it's being recorded so everybody knows who just joined, so that everyone can look at it later. I know people had things work and stuff today. So, okay, so let's get this PowerPoint up and we'll get started. Does anybody have any questions before we move on? No? Okay, so here we go. Will somebody tell me if you guys can see the PowerPoints?
I can see it.
Okay, thank you. Okay. Today's a hard chapter, you guys. It's pretty wicked, the things that can happen during pregnancy, and I'm just thankful our sweet little pregnant girl has already delivered, so she doesn't have to worry about this. I always hate that when students are pregnant and have to see all this. She gets to see her beautiful little boy. Okay, so let's move on. So, birth defects, unfortunately, it happens. The good news is nowadays we know so much more about genetics and gene therapy and what's chromosomal and things like that, that there's so much we can do. And that's why they continue to say why prenatal care is so important. So there's a lot of things that we can avoid if we can just get the right testing and help needed. So, anyways, birth defects are abnormalities that are apparent at birth. Okay. So it occurs in about 3 to 4%. Just a minute. I might lose you for a second because I have to admit somebody, and it always does that. Admit somebody to the meeting. I have to start over. I don't know why it does that, but let's do this again. There. Okay. All right. Can you guys see it again?
Yes.
Okay, thank you. Okay, so unfortunately, it occurs in about 3 to 4% of all live births. Now, some of them are obvious on ultrasound during the pregnancy, and some, like metabolic disorders and stuff, are not. So that's part of the problem, is we don't always know. We know a lot more, but don't always know all of it. So I wanted to show you on the first page. It's gruesome. Look at the one to the right. That is an actual picture of a baby. And this is what you would see. Remember, I told you guys about that acne drug Accutane? Remember, I told you 100% are what they, termed the teratogen little monster. That's, see why they say that? See why the parents have that fear? Look at that. That is just a baby who was completely put together wrong in the embryonic phase, right? So that drug or whatever happened to this baby, but let's just say it's Accutane, was taken by mama in the embryonic phase, and look what happens when they're being put together. And then this one is a conjoined twin, just didn't split correctly. So other kinds of anomalies. This one here, D, it is anencephaly. That's one of the neural tube defects, and it is no brain. Okay, so you can see this other one down to the left. That's probably either microcephaly or anencephaly, no brain. Just some very sad things. The first picture is fetal alcohol syndrome. So the abnormalities can be of structure, function, or metabolism. Okay, may result in a physical or mental disability, may shorten life, or may be fatal. We just don't know till we get diagnosed. What is C? C is, see the, I think it's trying to show you the left side of the face is droopy a little bit, and the eye is bigger. So either it was from damaged, or it looks more like it's might be some sort of syndrome. Yeah, good question. Okay. All right. So classifications of birth defects. So malformations. I had a baby born one time who was, and nowadays you'd see this on ultrasound, but she was born without an arm right below the elbow. And there's called embryonic bands that, amniotic bands that can cut off circulation to certain parts of bodies, and we don't know it, because you could see her hand, little fingers and a hand trying to grow out of it. The good news is when they're born with an elbow, there's so much they can do. And she came back. She works at our hospital. She came back and she's very open about it. So I'm not talking out of turn. And she came back and had a baby. And she just does phenomenal without that arm. And, they learn, most kids learn to live with their disabilities and how to compensate, right? So you can see this one picture, all the bones are just fused together there on the feet. And then the hands, the top right one, simian creases, that's consistent. We're going to learn today about Down syndrome. It's a solid line, and we'll go more over that. Then this bottom picture I thought was important to show you. Back in the day, remember me telling you guys the show called The Midwife? They really get into discovering thalidomide damage. Thalidomide back in the day, back in the 70s, 60s, was just this miracle drug for morning sickness for moms. And it would just, moms loved it. It helped them so much. Well, then they started finding in this one community these babies that were being born with either shortened limbs or no limbs, or just, and they really, really show it well in that show. That's what I love about it, what the families went through until they finally put it all together that it was caused by this one drug. And, it was a prescription medication. And so, of course, doctors felt terrible, but these families had these kids, just like this bottom picture, with no limbs. It was very sad. Anyway, so congenital malformations are defects present at birth. Then there's inborn errors of metabolism, which we'll talk about, PKU, things like that today. Disorders of the blood, chromosomal abnormalities like Down syndrome, and perinatal injuries. Something happened during, delivery or during the pregnancy that caused them to have something wrong. Okay, here's a question. Active and efficient participation in prenatal care can significantly decrease the risk of congenital anomalies.
True.
Because we can figure it out sooner, you guys. We can see what could happen, or what their diet is, what medications they're taking, all those kinds of things. What if they were on Accutane and they had a terrible doctor that didn't tell them not to get pregnant, and they did, and they just didn't know? Things like that, right? We could prevent that. So it's super important. All right. So then here's some neural tube defects, and these are real. These are, again, malformations present at birth. And it's most often, remember way back when, you guys probably don't remember, but I showed you a slide in the embryonic phase when the neural tube was being developed. And this is when these things go wrong. And it's most often caused by the failure of that neural tube at the closures. Okay. So you get hydrocephalus, which is water on the brain, spina bifida, and anencephaly. Okay. So women of childbearing age should be instructed, I'd remember this if I were you guys, to eat foods fortified with folic acid and take a multivitamin. Yes, Thea, I have it on. I'm pretty sure. Does it not look like I do? Let me make sure it says it is. Okay, thank you. No, that's okay, Thea. I'm just making sure that I'm doing it right. That's all. Okay, thanks, guys. All right. So this one down here, this bottom picture is another anencephaly and born without a brain. Now, these ones are a lot easier to find on ultrasound because of the shape, right? But some have normal looking heads from the outside. We got to see what's on the inside. All right, so hydrocephalus. So remember cephalic, ceph, right? Head, and hydro, water on the head, in the head. So it's characterized by an increase of cerebral spinal fluid. If I were you guys, I would know hydrocephalic babies inside and out. So it's CSF within the ventricles of the brain, and I'm going to show you a picture in a minute. So it causes pressure changes in the brain, causes increased intracranial pressure. That makes sense, doesn't it? If you have more fluid in that brain building up, then there's going to be a lot more pressure, right? So it can be evidenced by a bulging fontanelle. Remember we saw those pictures of the fontanelles that were sunken in? Well, these would be bulging because there's just too much in there. So increase in head size as it just continues to fill up with fluid results from an imbalance between production and absorption of cerebral spinal fluid or improper formation of the ventricles of the brain. So obstruction within the ventricles of the brain can also, it's not adequate reabsorption, can be congenital or acquired. In other words, can be something from conception or something the mom did caused it. So here we go. Here is on the brain. You can see the top part up there. See how much more fluid is in there, that blue, than the normal brain. And you can just see the pressure. So most of them are acquired by an obstruction like a tumor, or a mom had infection that caused something like that to happen. Perinatal hemorrhage, the baby bled inside for some reason. Symptoms depend on site of the obstruction and age in which it develops. So here is a prime example. This baby has already had surgery. You can see the sutures on the top of the head. And this baby has the classic, there's like sundown signs. It's right here. In advanced cases, the pupils appear to be looking downward and the sclera may be seen above the pupils. See how you can see that white above the colored part of the eye? That's abnormal. This baby is very, the brain is very affected by this. Yes. Hi, Selena. You have a question?
Sorry, that was an accident.
Oh, no worries. No problem. Okay, so classic signs. Increase in size of head. Key. Big time. Cranial sutures separate to accommodate enlarging mass. Scalp is shiny. Just think about something that's just growing, and it just gets so taut and shiny. Scalp veins are dilated. You can usually see their veins. In advanced cases, you see the eyes looking like that. So you can see how large the top of this baby's head is, right? That's absolutely not normal. Then here is very, very severe. So the top picture just shows no hydrocephalus, and this picture to the right is, see all that fluid and pressure in there? And then this bottom picture, I want you to look at the posture of this baby laying in this crib. That is severely central nervous system involved. Super, super sad. And can you imagine the pain of all this pressure inside a head like that? I can't even comprehend it. But when you see that kind of a posture on any baby or child, it is just they're cerebrally involved just horribly, horribly. That will never ever be a normal child. Something's very wrong. And then this one to the right, just look at this huge. So the sad part is this child never got a shunt put in, it looks like. And we're going to get to that. All right, so diagnosis and treatment. So transillumination. So see this top picture? So I'll tell you my story. So I had a patient come in, and tell me if I told you guys this one already, because we just seem to jump around in these chapters. And she was 15 years old and first baby, and she came in active labor, and no one knew she was pregnant. She went and labored on the bedroom floor or the bathroom floor, she told me. Sweet, sweet girl. I totally became attached to her. And she, her neighbor brought her in. And I said, don't you want family members or somebody here? And she says, no, nobody knows I'm pregnant. I want to put the baby up for adoption. Okay. Well, I check her cervix, and what do I find? She's dilated to 4, but it's breech. So she has to have a C-section. So I said, sweetie, you're going to have to call. Come to find out, she lived with her dad. And she was just so hush-hush that at first I was very suspicious that grandpa was also baby daddy. We've gotten many of those, unfortunately, from, incest, things like that. Why she was so fearful and everything. And I said, you know what, you're going to be in the hospital now for 3 to 4 days. You can't just come and have a baby. I know, Thea, right? Awful. We've had way too many of them. And so she ends up calling her dad and telling him, what's going on. We take her back for a C-section. Beautiful little baby boy, beautiful little guy. And we're going to call him Craig because I can't use his real name. So little Craig looks great. And remember, she's had no prenatal care because she didn't want anyone to know she was pregnant. Okay, we get a lot of no prenatal care. And so I get attached to this patient and this baby, and she just absolutely touched my heart. I just loved this little girl. And I mean, for me, 15 is still a little girl. I have kids, right? And so we started noticing, I was working several days in a row, and the baby was having a really hard time keeping his temperature up, his temperature and his blood sugars. And we were like, what is going on? So finally, I just put him in a warmed isolette and put him at the nurse's station with us to keep a close eye on him because he was starting to worry me. It was like I want to say he was at least 24 hours old when this was happening. Anyway, so I look over, I'm doing my charting and stuff at the nurse's station, and I look over and I see him going like this. And then the next thing I know, I see his feet going like this. We call it cycling. So that's seizures. So just as I was standing there watching this baby, like, oh no, look what we have going on now. The nursing supervisor walks through the door and says, is that baby seizing? I go, yep. So take it to our stabilization nursery. And we get him in there, and we are having a heck of a time stopping his seizures. I mean, we had to give him phenobarb and just so many medications. It was just awful. So we finally end up having to ship the baby to Modesto. So at this point, the mama has decided she might want to keep the baby. Her dad's on board now, and I met the dad. Seemed like a really good guy. The guy was actually disabled and really good guy. Come to find out, she really just didn't want to disappoint him. And then she shared with me that she went to a party and hooked up with a guy very first time she ever had sex and didn't think she could get pregnant, she did. And so she, she opened up to me. This was a long time ago, so I don't feel like anybody will know anything, but she gave me permission to talk about it anyway. But anyway, so we shipped the baby to Modesto. Most of our babies go there, and because they have a level 3 nursery, and it's a higher level of care. Okay. Well, and so then the mama got discharged and went with him. And then the next thing we hear is the baby was getting shipped to Oakland Children's. And we're like, oh, that's not good. That means it's something that even DMC can't take care of. So then, and this was years ago, so we had a manager who was wonderful, and we had where we weren't as busy back then as we are now. And because we get this call that says that they are discharging mom and babe from the hospital, and baby's going home to die because they found out he had no brain. Oh, God. So we also got a report in writing, and it said that the mom wouldn't believe them. And because the baby acted totally normal, you guys. The thing about it is babies only have to have a brain stem. It is so sad. It is so sad. I bonded with her like you can't even believe. So so babies only have to have, what we found with this baby, he had a little bit of corpus callosum that goes up the back into the brain. And so that's why he was more functional than some babies would be with no brain. And but all they need is brainstem for breathing and heart rate. That's why you hear vegetables, because they can function breathing and they can stay alive, right? So anyways, we couldn't handle it that this little 15-year-old was going to take this baby home to die with a disabled dad and no support. I was freaking out. So our manager let the baby come back to our unit as a patient, and mama was just a boarder with the baby. And the plan was to let the baby pass away. So what they did was they didn't feed him. Now, that sounds really mean, but it's not. They've done studies, and he actually was extremely peaceful. They've done studies that their gut isn't having to work and stuff as much. It's actually peaceful. And so we didn't feed him, but it took way longer than we thought for him to pass away. And so I came in and visited her every day. I brought her clothes, and just really, she touched my heart. Anyway, and so I had a note on the chart, and I said, when you guys think it's time for little Craig, that he's going to pass away, please call me and I'll come be with them. So they called me one evening, 8:00. I was at a friend's house, and I said, okay, I'll come in. So I came in, and it was just the most, oh, and by the way, in the meantime, we put they said over at Oakland that they put a flashlight up to the baby's brain, and it was just like this picture. It lit up like a light bulb is what they said. And that's when mom finally believed them that there was no brain. And so we did the same thing just to see for ourselves, and sure enough, it was just like that picture. It was unreal. It's just unreal. And so unfortunately, it was just a very hideous night. And what would happen is the nurse was on duty. She had to give the meds. I was just there for support because I wasn't on duty. And then mama and the baby. And he died 5 times. He would just do this horrible shuddering thing, turn blue, no heartbeat. We were all just crying and thankful that it finally happened. And then seriously, couple minutes later, he'd come back to life. It was awful. So the doctor gave us orders to be able to give him a little morphine just to help him be peaceful, you know. And then finally, at around 2 in the morning, Mama, I slept and I held the baby, and I just said, I'll wake you up when it's time. And so we all said goodbye to him and had the coroner come and get him. And it was just one of the most saddest, worst experiences. But then the only happy part to that is she came back a few years later, happily married, had 2 more healthy baby boys. And, you know, I've kept in touch with her every now and then and doing extremely well. So at least, you know, there's a happy ending to that. But I will never forget that little Craig and his mama. They just were dear to me. And it was just a really hard experience for everybody. It was bizarre. So anyways, that's what transillumination is lighting it up like that. Okay. So that's just pure fluid in there. All right. And then they can do an echo of the brain. Then CTs, MRIs, they can do taps, you know, to see what's going on with the fluid. So treatment is medications to reduce production of CSF. So the baby on top has no brain. So you're not going to treat it unless the baby's in pain. You're going to let that baby pass away. The baby on the bottom has a brain. So we have to do surgery to, you know, either medications or surgery to get that fluid level down of the cerebral spinal fluid. So the bottom picture, you can see the surgery is to place a shunt. You guys need to know that. They place a shunt, and you can see that it goes from that spot in the baby's brain and it empties out in their abdomen and it just gets absorbed. But parents have to be really, really careful because those shunts can get kinked and clogged. So parents have to keep a real close eye on it. Okay, so preoperative care. So sometimes they can do surgery in utero for this if they find it early enough so that it doesn't get so much fluid in there that's permanent damage. So, but if it's after they're born, we got to do frequent head position changes to prevent breakdown. Head must always be supported while being fed. Always have to keep track of head circumference along with vital signs, of course. And symptoms of increased pressure in the head are increased blood pressure, which makes sense, just pressure, right? All that pressure. And decrease in pulse and respiratory rate. I would know this slide if I were you guys. So not only can they have a loud cat-like cry when it's increased intracranial pressure, it's a shrill, it really does, it sounds like a cat. And then these vital sign changes. So here again is a picture of the shunt and how it works. They can also use antidiuretics. So, you know, furosemide, things like that, surgery to bypass shunt. So again, it just drains that liquid continuously. And there's this little pump. Can you see on the right side? You can see it says pump. And it's something that the parents can do. I don't know if it's externally, internally. I've never actually seen one myself, but somehow they're supposed to be able to try to clear it. So here is a baby that had a shunt put in. Yes.
Why does the liquid have to be drained into their inside of their body? Why not outside?
Messy and infection from going through a hole, and that hole would constantly be wet and moist, and it just works really well being absorbed by their own body.
Okay, thank you.
Yeah, you're welcome. So this is a baby. The picture should be switched, but this is the way the picture came. On the right was the baby before, and on the left is the baby after getting the shunt. Now, this baby, it's almost impossible that this baby will be normal no matter what. because it had all that pressure for so long, you can tell. And these babies can't deliver vaginally. Their heads are too big. And, but at least you can take a lot of the pressure off for, pain reasons. Now, this one I just thought was beyond comprehension. And these are children that don't have access to care. And that's when Doctors Without Borders, things like that, do absolutely phenomenal things, flying over and doing surgery on these kids. So this kid was in the hospital to get a shunt. Now, this child will never, ever, ever be normal, but I can't even comprehend the pain and the breakdown. And then look how shiny, see, the scalp is so shiny. And if you looked really close, you'd probably see a bunch of the vessels and stuff showing through. But isn't that just sad? Okay, so post-op care, of course, assess for signs of increased intracranial pressure, high-pitched cry, change in vital signs. Protect them from infection. It can be life-threatening. It's surgery in their brain. And depress the shunt pump is ordered by the physician, which helps with the drainage. And position dependent on all the factors, where it's at, just something that the doctor would place the order. Assess and provide for pain control, frequent skin assessments, head, chest, and abdominal measurements, because they don't want to build up anywhere of this fluid, right? And again, always with all these kids with anything like this, intracranial pressure is what you worry about. Again, high-pitched cry, unequal pupil size, bulging fontanelles, irritability or lethargy, poor feeding, abnormal vital signs. I would memorize that if I were you. Okay, now we get to spina bifida, which literally means divided spine. So it's a group of central nervous system disorders characterized by malformation of the spinal cord. But there's different degrees of it. So this happens in the embryonic phase, again, when that neural tube is closing. So there's two types. Occulta. Always remember occulta. You'll hear that a lot in nursing, and it means hidden. Remember we talked about umbilical cords coming down and being a prolapse cord. Well, sometimes the cord comes down, and that's why you always watch the fetal monitor strip after the doctor breaks the water, because the cord can come down and just sit here and get smashed in the shoulder, but you can't see it, but something is going on. It's hidden. Occulta, hidden. Okay. So then there's the cystica, which we'll look at that in a minute. It's a cyst or sac that it looks like. Okay, come on. There we go. Okay, so here is the different kinds. So here is on the left side is your just a little tiny defect. The middle one is where you see the sac on the outside, but it doesn't have any of the nerves in it. So that's pretty easy to fix. The third one on the right, see how the nerves are coming out with it? Those are the kids that usually have paralysis and things like that, which we're going to look at again right now. Right. So here's the occulta, hidden, right? So minor variation of the disorder, opening is small, no associated protrusion of structures, treatment generally not necessary, but if it's left undetected, you can see this child here with that big tuft of hair. It's something in an enzyme that's released. I looked it up, why hair. And it's something that's released in the cerebral spinal fluid and stuff that causes that growth of hair right there. And that's where the spinal cord came down and was just a little bit trying to come out, but not. And then this second one, the one on the top right, big old dimple. that means the spinal cord is tethered to it. And so it's being pulled in, the skin is, because it's tethered, okay, attached. And then you can see the one on the bottom left is a little tail, but that can have spinal nerves in it. Really? Was he okay? Did he have to have surgery?
No surgery. They did MRIs on him for every 3 months till he was 3. And
Wow.
then it's still tethered and it's still attached at the very bottom. But they said as long as he doesn't have like a major growth spurt, he should be okay. But they said if he gets injured in that area, he could get paralyzed.
Oh, that's scary. So no sports?
He's not allowed to play like sports for school, but he can play but he's able to just be a regular kid and play, but he's not able to like competitively play sports.
Yeah, like football where you get banged hard and stuff like that, huh?
Yeah, but I mean, boys will be boys, right?
Right. Was it a dimple? How'd you guys find out?
So it's a dimple just like that very bottom corner one.
Okay.
It looked like that, but it when I first noticed it, it looked like there's the baby wipes. It was like stuck in there, so I pulled it out, but it was like dead tissue. So then we took him to the ER, and then that's when they noticed it.
Wow, interesting. Thanks for
So his
sharing.
first MRI was when he was 1 month old.
Wow. And
Mhm.
they just said tethered cord? Is that what they
Yeah,
told
they
you?
called it a tether cord, and they showed us and everything.
Wow, interesting. Oh, thanks for sharing. Nobody has told me that before, that they've had that experience. Yeah, so good doctors and pediatricians, and I'm not saying yours wasn't, because sometimes it becomes more distinct as the baby grows, but every nurse and every doctor, when you do your complete head to toe assessment, always you look for a dimple there, always. Now, just because they have a dimple doesn't mean it's anything bad. You can see, like she said, look at the bottom right one. It's just a little tiny dimple, right? And a lot of parents think, oh, just a little dimple. Dimples in babies can mean things, unfortunately. And again, not always, but it should be like this yellow light to you going, caution, we need to make sure it's nothing bad. We need to rule it out. Okay. So what they would do if they found this in the hospital is first they would do an ultrasound, and then they move on to MRIs and stuff. But her baby was older, so they probably just moved on to the MRI. But right after birth, that's what they do to see if it's tethered. Okay. All right. So here is the cystica. So we had a patient come in, had prenatal care, everything. All of a sudden, I wasn't the nurse. And she was someone a lot of us knew her. She works in town and everything, and the most wonderful family. And the baby delivered, and one of the nurses comes running out and says, "We think we have a spina bifida." And I'm like, "What? We just don't get spina bifidas because they're always found on ultrasound with people with prenatal care." And so I was like, "What?" So I had to go down and look for myself and help take care of them. And it was like this bottom one. It had this weird little area. And what that is, you guys, is the nerves. So in this sac is the nerves and cerebral spinal fluid. And so I was like, oh my gosh, I've never seen one of these before. So I ran out and we were calling the pediatrician of how to take care of it. And we called down to Doctors Modesto. And then when I had a minute, I looked up her ultrasound because I was like, how can this even be? Well, every ultrasound she went to, the baby was turned at such an angle each time the radiologist said, unable to visualize the spine. So it was nobody's fault, but usually they deliver at a high risk place so that they can take care of it immediately. So this is what they look like. And you cannot let that sac dry out. We had to put saline. I think I have that here in a second. Yeah, we get to that in a minute. I'll tell you the care. Anyways, you've got to know the differences, you guys. This is the meningocele. This is the one without the nerves out. See that picture? It's just an outpouching and that cerebral spinal fluid in that pouch, but no nerves. Okay. So size varies. If no weakness of the legs or sphincter involvement, surgical correction is performed just to get rid of that sac because you don't want it to open up, or it is cerebral spinal fluid, but it usually excellent results. Usually there's no further issues with this type. Now, this is the one that babies have issues. And our baby that we delivered, this was what he had. It was a myelomeningocele. Okay. So it's a protrusion of the membranes and spinal cord through the opening. May have associated paralysis of the lower extremities. We found out later he walked and stuff, but he had problems with bowel and bladder control. And so you can see they can have that. And hydrocephalus is a common complication. Has all to do with that cerebral spinal fluid buildup. And he didn't have that, but kids can have that. All right. So treatment of spina bifida, surgical closure. And again, prognosis is dependent on how big it is, how much, if it was handled properly. And surgery, it's also for cosmetic purposes, the surgery, and prevent infection, of course. Okay, so nursing care. You got to know this. As nurses, what do we do if a baby's born with spina bifida? With that baby, we called and got instructions. You place them prone, so face down, of course, and obviously you want them off that sac. So it makes sense that you'd want them face down, right, to keep that sac up. And you have to keep a moist. Do they have strict INO when they have? Yes, these kids have to have strict everything. Yes, good question. Definitely. Okay, so moist, sterile dressing, because you don't want that sac to get too dried out and then get cracks in it, and then bacteria get in there. That could be deadly, right? So, and it's usually a saline or antibiotic solution. And absolute priority to maintain integrity of the sac. If you were asked any question about it, it's maintain the integrity of that sac. And we do that by placing the baby prone and putting moist dressings on it. Okay. Usually the infant's hips are kept lower than the lesion, and diapers are usually just laid under them. We don't put it on unless the sac is way high. Okay. So cleft lip. So there's cleft lip, cleft palate, or both. Okay, not always both. So cleft lip is characterized by a fissure or opening in the upper lip. It used to be called hair lip back in the day. It's failure of the maxillary and median nasal processes to unite. Do you notice the theme here? All of this happened in embryonic phase. So remember, what's the embryonic phase? How many weeks of pregnancy? So we have the zygote, embryo, fetus. Come on, someone knows it.
1 to 9?
So
No, I think I'm too far out.
yeah, two to the end, to the 9th week, weeks. Remember, 2nd week to end of the 8th week. Remember that embryonic, you guys? 2 weeks. Then fetus, 9 weeks to delivery. Is that sounding familiar? You guys got to refresh your memory and remember all this. Okay, really important. Okay, so remember, embryonic, when so much is being formed, and that's when a lot of people don't even know they're pregnant yet, is part of the problem.
How many weeks did you say that was?
2 to 9. So 2 to the end of the 8th week, right? 2 weeks of pregnancy to the end of the 8th. Then fetus starts 9th week to delivery.
Thank you.
Okay. Sure. So this is what's kind of interesting too. Now that they have figured out all the genomes and, figured out what every gene is coded for, they have found that some of this is autosomal dominant. So in other words, this trait can be passed down through the families if they have that trait, and appears more often in boys than girls, can occur in one or both sides of the lip, can be slight or severe. So here's picture. So the poor little one on the left, look at how severe that is. Then the middle one is an incomplete cleft lip, just a little bit of a thing. And then the one on the bottom right is double. But the beautiful thing is used to be, you guys have seen, I don't know if you know anybody, but when I was a kid many moons ago, it was very obvious when they had that, and they were called hair lip back then. It was just what it was called. It wasn't being mean. That's just what they called it. I don't even know why, actually. And look like a rabbit. I honestly don't know. But now plastic surgeons can do absolutely amazing things for these kids that you can barely even tell that they ever had it. Okay, so treatment is cheloplasty, and it's a repair that the surgeon does before 6 months of age. They oftentimes have to be in restraints because it bugs them and they want to, itch at it and stuff. They have to have a special syringe or bottle. And by the way, before surgery can happen, so say I worked tomorrow and I had a baby born with cleft lip, cleft palate, either one, there's a special type of bottle that every nursery should have for these kids that helps them not get food where it's not supposed to go, because they have that open area depending on how severe it is. Plus, if it's just the lip, they can't get a good suction. So we just have tools to help them eat better. Okay, post-op care. So we've got to prevent them from sucking and crying because we don't want to break up. So they're often tube fed. Careful positioning, of course. We want to help prevent infection. And so we, clean it with sterile water. And of course, they still need cuddling and snuggling and all that stuff. They need to not feel like something's wrong with them, and appropriate pain relief, of course. All right, cleft palate is when it's the whole palate, and sometimes you don't see it but this is cleft lip, cleft palate. Okay, so it's failure of the hard palate to fuse midline during the 7th to 12th week of gestation. So embryonic into fetal. And it forms a passageway between the nasopharynx and the nose. So it's open up into the sinus, up in there. And that's why they can get such bad infections, sinus and ear and all that kind of stuff. So, and respiratory tract. So we've got to really keep on that. So, because it could cause hearing loss as time goes on. So you can see up at the top, well, down at the bottom first, let's see something happy. Look at that baby. And that's before and after. Isn't that amazing? I just find it absolutely amazing. And they'll probably down the road be able to do one more surgery to completely get rid of any sign of it. But the top I want to show you, I only found one cleft palate. It was interesting because I always, put a glove on and use my little finger. And when I do my assessments, the pediatrician does it, but I like to know for myself. I always put it in and feel the whole palate to see if I feel a little hole or not. And we found one time. It was in the very back, kind of like that picture up there on the right that says cleft palate. And it was just a teeny tiny little hole in the back. So we just had to use that special bottle and stuff until they could sew it up. Okay. So post-op care for these kids is just a little bit different because it's their whole palate, right? So diet is progressively advanced, no food through straws or sucking because the pressure can get knock the scab off and cause issues. So follow each feeding with clear water to cleanse the mouth, help with their speech as they go along, if they need speech pathologists, whatever the case may be, and help with keep them from crying. Let's divert them from things that make them upset, right? And again, complications can be ear infections and tooth decay. Clubfoot. Now, often kids are born, babies, with a curved in foot, but that's just the way they were lying in utero. It was laying up against the wall of the uterus or whatever. And oftentimes can do physical therapy and just get it straightened back out. When a baby's born like that, we've got to do x-rays and see if it's the bone versus just needing some physical therapy. So true clubfoot is the most common deformity. It's the foot twists inward or outward. And I don't even know how you say this, talipisiquinverus, you can read that. Anyways, feet turned inward, child walks on toes and outer borders of feet, generally involves both feet. But they have to be casted, things like that. So it just depends on the severity, how much is involved, and all that. Okay, now you've got to know all there is to know about hip dysplasia. Okay, so developmental hip dysplasia. So it applies to various degrees of deformity. So subluxation or dislocation. So partial or complete of the ball of the hip up into where it sits, right? So the head of the femur, the ball, is partially or completely displaced inside the socket. 7 times more common in girls. And I don't know why that is. I think it just has to do with their anatomy of their bone structure is different. More apparent as infant and toddler begins walking. So it's usually discovered at a routine health check. Now, what I can say to you is I found one myself, and pediatricians check too. But when I do my assessment, and you have to find out what's in your scope of practice at your hospital, but I would take the baby's legs and put them up and out and back down again. And that if you hear a click or feel a click, oftentimes that tells you that they might have a dysplasia. And then the doctor would order tests to find out. So what usually happens is one leg appears shorter than the other. You got to remember this: asymmetrical gluteal folds. So look at these pictures down there. See all those folds in that thigh? That's the gluteal folds. And see how they're asymmetrical? Look at the left leg and look at the right leg. Very obvious, isn't it? Okay. So most reliable sign is limited abduction of the leg on the affected side. So how I always remember add and ab is you're putting it together is adding versus subtracting away. So abduction is when, remember I said I went like this with the legs out. Okay. So when infant is in a prone position, one buttock appears higher than the other. The treatment. Are we going to try to power through today and take breaks and get done early?
Yes.
So do you guys just want at 11:30 to power through, take your 10 minutes, do whatever, if potty breaks, whatever, officially we have to say that, right? But if you guys want to just power through and have a quick lunch at 11:30, we can get done for the day earlier since we're doing this on a Saturday. So it looks like everyone's saying yes to that. Okay, good.
Can
Yes.
we skip lunch?
Yes. Okay, good. So we'll power through. So when you guys are, if you need a break or need anything, but otherwise I'll stop at 11:30 we can even skip lunch too. Let's take a vote. If you guys want to do that, I'm happy to do that. But you guys, here's the thing. We're on being recorded, but legally, if anybody wanted to say anything that they didn't get a lunch, but you're at home, you could eat while we're doing this. So, okay, looks like everybody would rather get done early today and skip everything. Okay, so you guys just let me know, be right back, whatever, if you have to run and get something, and, you know, in the chat, and we'll just power through. Okay. And then we can have the rest of our day, huh? All right. And we don't have a quiz today, so it should be pretty good. Yeah. Especially you guys working and stuff, right? All righty. Do what we got to do here. Good job, guys. All right. Treatment of hip dysplasia. So hips are maintained in, you're welcome, in constant flexion and abduction for 4 to 8 weeks. Can you imagine? I don't know if any of you have had kids that have had to do that, but it's not fun. Parents I have talked to, oh my gosh, it's not easy. But they've got to keep the head of that femur in that socket. So they can use a Pavlik harness, which I have a picture on the next slide, to provide the necessary positioning. So I would know all about Pavlik harnesses. Education extremely important for these parents. We have got to prevent skin breakdown because there's all these straps and stuff, right? So the skin under the straps, the baby's skin should be checked every 2 to 3 times a day and make sure it's not causing breakdown. And surgical intervention sometimes is necessary. So here, the left one is the Pavlik harness. So you can see all those things. And do you see how the baby's legs have to be out like that? Abducted. And then the middle one is a body cast. And you can see how it has an opening there for pee, poop, things like that. But can you imagine? That would be awful. And then the right is if a baby has to be in traction. They got creative and put the baby in a little wagon and all comfy. But think about, it's a month minimum that these kids have to be like this. I can't even imagine. I love that baby on the left is smiling, right? So this one I wanted to show you. One of my former students had this. Didn't get diagnosed till she was a teenager, and she said she started limping in sports. And just really bothering her hips, just started really bothering her. So the doctor took x-rays, and sure enough, she had terrible hips. And look at, after surgery, all the pins that they had to put in her as a teenager, which if they would have caught it as a newborn, she could have probably avoided all this. But it was awesome that she shared this picture with me. That's what I love it when you guys share pictures and stuff, because I like it when it's the real deal, you know? We had a baby. I can't remember if I told you this one. Sometimes you guys are just going to get repeat stories. But anyways, I wasn't taking care of this baby, but I went in to help my friend get vital signs on the mom and babe. She'd had a C-section for breech. And breech babies, when they're born, depending on if they're footling breech or frank breech, most of them are frank breech, which, remember, means the butt's coming first. The legs are like this in utero. Okay. So the legs are really, so every time you go to change a breech baby's diaper, you're trying to change their diapers and their legs go like this. And you have to try to hold them down to get them wrapped up and everything. And that's just the position they're used to being in, right? So what happened with this baby is just fussy baby. And I remember I went in and to do that, the vitals and everything. And she just looked at me and she's like, oh my gosh, tell me he's not going to be like this. He just cried and just fussy and just, we couldn't get him settled. And we're like, it started to get to the point where what's going on with this kid? This isn't just a baby who's hungry or needs a diaper change. But we knew the pediatrician was coming in shortly to do the assessment. They come in usually pretty quickly after a baby's born to do the assessments. And so the doctor came in and did the test, the hip thing, and both hips were out of joint. And that's why that baby was screaming. We all felt so bad, but breech babies, they all do that with their legs. So we just didn't know. And that nurse knew the doctor was coming, so she didn't do the hip clip thing, which might have been a good thing because they were out of joint and it might have just made things worse. So those are things that, if in doubt, have the pediatrician do it, right? So anyways, completely out of socket, both of them. So poor little guy, but at least the mom was so relieved. She's like, there's a reason for him being such a unhappy baby. So needless to say, we gave him Tylenol and, everything we could to get him calmed down and comfortable. Okay, metabolic defects. These are hard ones because they don't show up. And oftentimes the symptoms show up before you can get a diagnosis. So they're inborn errors of metabolism. It's a genetic defect that may not be apparent till after birth. PKU test is done to obtain early diagnosis. Now, PKU stands for phenylketonuria, but when it's called the Guthrie test, just a minute, I'll show you this one right here. This on the right, that picture, that's called the Guthrie test. And you get all these, you have to fill up all those circles, both sides. Brittany has probably done this a million times, but it has to fill up so that both sides fill those circles. And it doesn't just test for PKU, it tests for all different kinds of metabolic disorders. So that's the whole point in them saying inborn errors of metabolism, the PKU test is done. Originally, it just tested for PKU, and then they totally expanded what they check for. It's a state test. We send the forms into the state, and what happens is if it comes back positive, then the parents are notified and the pediatrician's notified. They retest, make sure it's a true positive, and then we'll discuss right now what how they treat it. So symptoms that we would want to report are lethargy, poor feeding, hypotonia, unique odor to the body or urine. It's a musty smell, tachypnea, vomiting. So all those are any baby with those symptoms you would report to a doctor, always. If just even in doctor's orders, pediatricians, their standing orders, it literally says just doesn't look right or just doesn't feel right. I can't remember exactly how it's worded, but because babies can be just so different. You just have to really know what's normal and what's not in a newborn. Okay. So the PKU is phenylketonuria. All right. It's a faulty metabolism of phenylalanine. So if you ever take biochem, you will learn all the coding, what tyrosine, all those things that are coded billions of times a day. So this is one of the things they're talking about with the coding of the DNA. So it's an amino acid essential to life and found in all protein foods. All protein foods. Think about that. It's transmitted by an autosomal recessive gene. So 1 in 4 kids could get it if both parents carry it. So another thing, they can be aware of that. If they know it runs in the family, they test parents ahead of time so they know what they're dealing with. So the hepatic enzyme phenylalanine hydrolase needed to convert phenylalanine, so tyrosine, see that right there? Not to confuse you, all it's trying to say is an enzyme that is supposed to be coded inside the chromosomes is missing. So then that makes it where the infant is unable to digest the essential acid, and the phenylalanine accumulates in the blood. It's found in the urine within the first week of life. So what used to happen before we figured all this out is babies would go home perfectly healthy, eat good. All of a sudden they'd start to get lethargic a month or two down the road, and they'd get brain damage and die. And they didn't know why until they started, those genomes and figuring all that out. And then they realized it was this gene. So it results in severe mental retardation or death if it's not caught early. That's why we do it in the hospital, this test. So early detection is paramount. Right. So again, baby appears normal at birth, and sometimes by the time we get the testing back, they can already have some brain damage. But we catch it pretty quick these days. We send it in really fast and get the results pretty quick. So delayed development apparent at 4 to 6 months. They can have failure to thrive, which just means they can't gain weight. They don't eat right. They just are puny and just aren't thriving well. Child has a musty odor, personality disorder. And this is another part of this tyrosine is occurs mainly in blonde, blue-eyed children, which results from a lack of tyrosine. Tyrosine is needed for melanin formation. What's melanin? What colors our skin, right? Isn't that interesting how all that comes together? So this is the Guthrie test. And like I said, we send it in. And it needs to be obtained within 48 to 72 hours after birth. But the key is it has to be done after the baby has had a good feed, because it's showing if it can break down those proteins in the breast milk or formula. Okay. So it is a state mandated test, at least in California. Parents can refuse it. They have to sign a waiver, but otherwise every baby gets it and can be repeated. It said that was kind of important in the ATI book. I hadn't heard that part. I put it on there for your sake, but oh, speaking of which, you guys, our campus doesn't put together the syllabus. We have input at times, but I want you to know that it said today for ATI, chapters 12, 16, and 17 in the ATI book. I would study chapters 12 and 17 for the next class. And as I was doing the quiz yesterday and stuff, I realized that it was definitely put in the wrong spot for, I don't know who puts it where. I don't know why they figured it would be this week, but it's not applicable today. So
Miss Casey,
yes.
are you are you able to go through maybe at the end or even now if you want to talk about it, like the quizzes that we're going to have on Wednesday and what chapters are going to be covered with which test or quiz?
Absolutely, absolutely. And I'm hoping if we have a little bit of time, we don't have to, but I have another quiz to kind of go over. I feel like it's kind of important. We'll see what time we get done, if it's early enough today. But yes, at the end, let's go over that so you guys have it fresh and have time to write down your notes and stuff. But I have one of the other quizzes. I just feel like it's important because the final two, you've got to understand a lot of things that you guys missed and why. I was glad we got to go over one last week, but so I have one quiz we might go over depending on what time we get done today. And yes, we will absolutely go over what our plan is for Wednesday. Okay.
Okay.
Don't let me forget. Don't let me forget at the end of class. Okay. All right.
Okay.
Okay. All right. PKU treatment. It's close dietary management. So they have to be fed. There's special formulas. They have to make sure that that fetal alanine doesn't get messed up. The protein has to be kept out of the baby's diet. And when I've talked to parents who've had kids with positive PKU, the kids, thrive and do well if it's caught, right? But what they said, what's super hard is when they're in school and other kids are eating their lunches and it looks so good and the kids share and things like that. The parents have said that's when it's really hard. And it's really hard to tell them no, at parties and all that kind of stuff, which you could see that would be super hard. But the other thing to remember is children with PKU must avoid aspartame NutraSweet, right? Because it's converted to fetal alanine in the body. All these enzymes and stuff, it's amazing. It matters. The physiology of everything. That's why it just fascinates me. Just one thing affects another, affects another, affects another, right? Okay. Down syndrome, also known as trisomy 21. So, how many chromosomes does a baby have?
Is it 23?
So 23 from mom, 23 from dad. Remember 46? Very good. Very good. But no, you're on the right track. Excellent, you guys. We need to review this. So 46 total. So trisomy 21 is the 21st chromosome. There's 3 instead of 2 pairs. There should be a pair instead of a tri. Okay. So it can even be a piece of one. So it's one of the most common chromosomal abnormalities. 1 in 700 live births in the US. Risk increases with mothers 35 years and fathers older than 55. Remember, it has to do with old sperm and old eggs, right? They just don't function as well. Infant has mild to severe mental retardation, and highest congenital anomaly is cardiovascular and some physical abnormalities. You can usually, when you're out in public, you can usually tell when a kid has Down syndrome, right? And we're going to go over it in a minute. But I have one of the stories I love to tell is we had this patient come in and she said she was having the baby, and she told me she brought party hats, and she said it's going to be a fabulous day. We're so excited about this baby, but our baby has Down syndrome. It's like, okay. And then she said, we are going to love this baby. It doesn't matter. And so we don't want anyone to be sad. We want everyone to be happy. And she said early in pregnancy, she hadn't found out that, she hadn't had all the diagnostic stuff yet because she was early in pregnancy still. But she said she was out in her garden, and all of a sudden, this hummingbird flew up and just hovered over her belly for 15 minutes. And she said, I knew right then and there that there was going to be something special about my baby. And her next visit to the doctor, they diagnosed Down syndrome. And it was just her attitude about the whole thing. And it was just absolutely amazing. So anyways, the baby was born, but didn't have severe trisomy. It was a fairly mild form, which is good, because the severe, I think I might have told you guys about my little Jimmy down in Southern California, that the mom thought she was going through the change of life. Did I tell you guys that one? For some reason, I thought I talked about it early on.
No,
Anyway, say that again. Yes.
you didn't tell us about that one.
Okay, I'll tell you real quick because it was very interesting. So she was like 47 years old, a Hispanic lady, thought she was going through the change of life. She thought her belly was growing. She had 2 teenage boys at home. Thought her belly was growing. She was scared. She thought she had a tumor. Finally went to the doctor because it was growing, and her husband was like, this is ridiculous. We got to get you to the doctor. And normally when people say they didn't think they were pregnant, it's like, come on, how do you not feel the baby kick and grow? And, and I do know denial can be a strong thing also, don't get me wrong, but sometimes it's like, really? But this time it was totally legit. So she had just found out she was pregnant. The teenage boys were so excited about it. And I put her on the monitor, and the fetal monitor strip looked horrible. I mean, horrible. So we did an emergency C-section. We had the NICU team there, and they made the incision. I'll never forget it as long as I live. And they were bringing the baby out and just got to the eyes, and I could tell it was severe Downs. No question. They continue bringing the baby out of mama, and webbed neck, just everything, the most severe Downs you can have. And so we grabbed the baby. The NICU team took the baby to the NICU nursery. And I remember the boys standing out in the hall because they named him Jimmy. And I remember they were just tears coming down their cheeks because they knew something bad was wrong with their baby brother. And I went to visit him in the nursery later, and he had a shared atria in his heart, which is the worst defect with Downs that you can get. So he was incompatible with life. He wasn't going to live. And I just remember just how terribly sad it was. And I visited him. He lived for like a week or two. And you know how last week we talked about necrotizing enterocolitis? Remember that? The bowel gets all dead. Well, I guess he got that because I went in and they had done abdominal surgery on him. And I said, if he's not going to live, why in the world would you do surgery on him? And they said, because he was getting neck, and that is so painful that they had to take care of that, you know, while he was passing away, so that he'd be comfortable and not in agony, which made total sense. But I thought, oh, how sad. He had to have surgery and all that. But anyways, and the reason why it was really legit with her not knowing she was pregnant is severe Downs babies don't move. They're very hypotonic. They don't move. So she didn't have fetal movement. So that's why she didn't know. She was scared. It was a sad day. And then I have another story in a second. So there's 3 phenotypes. Trisomy 21 is the most common. So there are 3 number 21 chromosomes instead of the usual 2, and results from non-disjunction, failure of the chromosome to follow the normal separation process into the daughter cells. Just the process just got messed up. Okay. So mosaicism means they have normal and abnormal cells. Those are usually kids that are very higher functioning and stuff, and less severely, their appearance isn't as affected. And then there's translocation of a chromosome. So a piece of a chromosome in pair 21 breaks away and attaches itself to another chromosome. So we had one time, same thing, came in, she was from out of state, and we thought there was a little inbreeding going on, and they were from the backwoods of this. Anyways, it was kind of a bizarre situation. Anyways, and again, had to do a crash C-section because the strip looks so bad. We get this little baby out, and at first we're like, it's a boy. And then we're like, wait a minute. Is that a clitoris or is it a micropenis? So the baby wasn't doing well. Take it to the nursery. Pediatrician comes in and started cardiac issues and had to ship the baby out. Well, mom came back a few months later with the baby to say hi to us and show us the baby. He had a tube, and well, come to find out, he had trisomy 17. What they said was a piece of another chromosome broke off and attached to the 17th chromosome, and incompatible with life. So that baby would pass away by 18 months of age. Had all these tubes and cardiac, and it was so sad. But those are the things that we don't aren't always able to catch on ultrasound, because it's chromosomal, right? So here's probably my favorite Downs story. Had this patient come in, was her third baby. Was someone trying to say something? No? Okay. Anyways, third baby, 2 boys at home. And I said, so do you know what this one is? And they said, no, but of course we're kind of hoping for a girl. They didn't want to know. So she wasn't ready to be admitted. So I sent her home. She came back a few hours later in really active labor. Okay. So, but at that moment, when she was getting close to delivery, I ran out to call the doctor, and come to find out he's back doing a surgery. And by the time I could get another doctor in, she was delivering. So I just ended up delivering the baby. And I remember looking at the baby and going, I looks a little downsy to me, but it's hard to tell at first when they're really mild. And sometimes you look at the parents and go, oh, maybe that's just, the way this baby looks right now. Anyway, so baby acted fine, cried, put the baby to breast, all that good stuff. And, but went out, got the assessment, everything done, and got them all stabilized, went out the door to go get something. And I see the pediatrician there to do rounds. And I said, Kelly, please go in there and tell me that baby's not Downs. And he goes, okay. So he comes back out and he goes, sorry, babe, can't tell you that. I think she has Downs. And I was like, oh man, I was afraid you were going to say that. And not that it's that horrible. It's just, it's not the best future. Anyways, and so what was so cool about this one for me is I walked back in the room and both the parents, at first I thought they were upset with me. Both the parents said, did you know? And I said, I thought so, but that was for the pediatrician to say. It wasn't my place to say. And they just looked at me and they said, you know what? Oh, and by the way, it was their little girl. And I was all excited when the baby was born. And I'm like, it's your little girl. You got your girl, and everyone was so excited. Anyways, and they looked at me and they said, you know what? It doesn't matter. We wouldn't do anything differently. We will love this baby with our hearts and souls. It doesn't matter. This is the gift God gave us. I was like, oh. So this picture, it reminded me. That's why I have it on here. So go forward, probably 2.5 years. I'm in the bleachers, and it was just concrete things you sit on. It wasn't seats at our high school up here. And my son was doing football practice. And so I was just sitting there watching him do practice. And down a few rows, I noticed this dad down here and this mama over here, and this little girl just squealing with joy, running to daddy. Daddy would lift her up and squeal, 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 put her down, run to mama, just like this picture, and squeal, 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 happy, happy little thing. And all of a sudden, I'm like, oh my God, that's them. And it was just beyond heartwarming seeing they adored this little girl. She was so happy, and it was just the neatest thing to see down the road, and just it was their precious girl. And these Down syndrome babies can be amazing kids. They can be so loving and just they could be really neat kids to have. It's just, hard to have a baby with something wrong like that. So manifestation of Down syndrome, close set and upward slanting eyes. See that A picture? Look at the eyes there. Then small heads, round face, flat nose. See how the bottom of the nose, there's just a bit, and then see how flat it is up this way? Simian crease, so that's the top right picture. It's a line that doesn't have a break in it. So if you look at your own hand, you'll see probably 2 lines. Well, these kids have just one line that goes straight across. It's called a simian crease. It's just a sign. If you have it, doesn't mean you have Downs. It's just a sign of Downs. It's typical for Downs kids to have it. They are cutest, happiest babies. They are loved. They're just loves. They really are. So the other thing they have is a protruding tongue, which I have a picture in a second. They are mouth breathers. And hands are short and thick. That's that picture there. You can just see the fingers are kind of stubby like that. And they're curved, small, wide space between the first and second toes. So that's on this picture. See this one on to the right? See their enlarged tongue? And then I was trying to find, down here at the very bottom of this one in the middle. See the widely separated space between the toes? That's a sign. And then they have these, it's called intercanthal folds. it's right here in the eyes. They have that extra little piece of skin that kind of goes, this baby down on the right, you can kind of see has those little folds, and see the tongue, the flat nose right here, the slanting eyes. Usually most Downs kids are pretty obvious. Okay, so manifestations, they're very hypotonic usually. They just don't have a lot of good tone. And so they're more difficult to position and to hold. Physical growth and development is probably going to be slower. They are usually limited intellectually, but a lot of them are very high functioning and very lovable. Congenital heart deformities can be associated, not with all of them, but can be. Prone to respiratory and ear infections, and incidence of acute leukemia is higher. And I had to know why. I was like, why would it, just because they have an extra chromosome, why would that make them get leukemia? And I looked it up and it said due to increased expression of a protein on that chromosome. I just thought that was really interesting. Alzheimer's disease more common if they reach middle adult life. And of course, you want to always let parents express their feelings, talk about it, get them in with support groups, things like that, and provide with, any support they need. Right. So we've gone over this some already, but we're going over the really bad stuff that can happen with blood type abnormalities. Okay. So it's called hemolytic disease of the newborn. So hemo, blood, right? Lytic, it harms it, right? So it's called erythroblastosis fetalis. So erythrocytes, right, in the blood. Blastosis, they get damaged in the fetus, right? So it becomes apparent in utero or soon after birth. So this is where the Rh negative mother has an Rh positive baby, or there's an ABO issue. Like I think I've told you, my stepdaughter Carly is O and her husband's A, and the kids were A, and her body attacked. What happens is mom's body just sees that as a foreign body of something that's not supposed to be there. So even though maternal and fetal blood do not mix during pregnancy, small leaks can happen and allow blood to enter the maternal circulation, causing mom to start building up those antibodies and destroying the fetus's erythrocytes. Okay, so it can cause anemia and heart failure in the growing fetus. And that's another reason why we need prenatal care. We can catch these things and do stuff. We can do surgery. They do what they call pubs, that's blood transfusions, things like that in utero. So there's just so much that can be done now. So this is just showing an example of when you hear that they are sensitized, it means that the mom has already grown antibodies to that blood type. So I remember telling you guys about that one that she came from Mexico. She didn't remember getting a shot after her first baby. She was negative blood. And when the second baby was born, it was in bad shape. And remember, I told you that within an hour, the baby looked like a pumpkin with jaundice. And so that's what we're talking about, is something like that. So her first baby must have been positive blood. So mom already had antibodies. So the second baby was positive blood also. And mom started attacking that positive blood. So you've just got to always remember, because there's almost always questions about this, because it's so important. Because I think I told you that back in the day, people couldn't get married without getting a blood test. And that's why. is they wanted to see blood types, because before we had phototherapy and ROGAM and all those kinds of things, babies died. And so people would go in, get their blood test, and if dad was positive and mom was negative, they'd say you may not want to have children because of your blood type. But now that we have ROGAM, we don't have to worry about that anymore.
So the maternal to whatever.
Sensitization, yes.
Yes. Does that mean you said mom already has the antibodies and attacks, or mom already has the antibodies and allows life, I guess, or doesn't attack?
Yeah, no. If she builds antibodies, that's what she will attack. So, like with this one I was just telling you about, I should have clarified that. So her first baby had to have been positive. She was negative. So since she didn't get ROGAM after birth, she got all those fetal cells in her system and didn't get ROGAM to take those fetal cells out. So now with the next pregnancy, it's that same blood type, and that mom still has all that stuff in there saying that's poison, that's poison. I need to get rid of that positive blood in the new baby, if it's a positive blood baby. Now, if the new second pregnancy, if they're both negative, they're fine. Yes. But sensitized just means basically mom didn't get ROGAM and built up antibodies to fight off that foreign blood. Yes.
Okay. Okay. Thank you.
You're welcome. Okay. So the manifestations. So when a baby's born, if they have any blood type issues that we know of, so we do, every time a baby's born, you send cord blood to the lab. They run the cord blood if the mom is negative blood or O, because of ABO incompatibilities and negative positive. Okay. So if the baby's blood type, so mom's negative, if the baby's blood type comes back as a positive, then they do further testing, and it's called a Coombs test. And if it's positive, it just means that baby's probably going to have issues with hyperbilirubinemia, jaundice. Okay. So those kids, we usually have to put under Billy lights. So symptoms can be anemia caused by hemolysis of large numbers of erythrocytes. So again, remember erythroblastosis. Their erythrocytes are getting damaged. So right here, you guys, highlight, star, whatever you got to do, you've got to know about pathological jaundice. It's the kind of jaundice that occurs within the first 24 hours of delivery. Just remember, it is never normal for a baby to be jaundiced in the first 24 hours of life. It's just not normal. Now, third day of life, fifth day of life, sure, not in the first 24 hours. Okay. So what happens is the liver can't handle the amount of hemolysis that's going on, the lysis, the breaking down of the erythrocytes. And so the bilirubin, the byproduct, gets built up in the baby's blood. So then they get enlargement and edema of liver and spleen, and they're at major risk of shock and heart failure. So it's super important for us to find this stuff early. And on ultrasound, if someone gets prenatal care, they can start seeing, it's called hydrops. They can start seeing the swelling. And I think I have pictures of that in a minute. No, I think we did that one before when we talked about blood type issues. Anyways, it's just swelling around the major organs, and it can kill a baby. All right. So treatment is phototherapy. So putting them under the Billy lights. Okay. So remember, eyes have to be protected from the Billy lights. Cover the eyes, and got to remember this, encourage the infant to breastfeed every 2 hours or feed every, so many hours, because remember what I told you guys before? This is how the baby gets rid of the bilirubin. It poops and pees it out. That's the only way it can get out of the body. So we've got to keep that baby well hydrated. So you always cover the gonads. You've got to keep as much of the baby uncovered under the billy lights as possible, so the billy lights can get to that bilirubin and break it down. It doesn't go through clothing. So that's why they're in the warmed isolettes. And then always observe the color of the baby, and are they getting lethargic, things like that. But when babies are under billy lights like this, they get tested quite frequently to make sure their levels are going down instead of up. Because remember, if it's too much of a buildup of this, the hemolyzed blood, hemolytic, then remember that's what can build up in the brain and cause kernicterus brain damage. So we have to really keep on these kids. So now this is interesting at the bottom, because sometimes if we can't get the baby to eat well, we have to put a line in their umbilicus, like an IV line. But once the umbilicus starts drying, you can't get a line in there. So that's why they say apply wet, sterile compresses to the umbilicus if there's any thought that the baby's going to need blood transfusions or, more fluids, things like that. We want to keep that cord moist so we can use it if needed. But that would be something the doctor would order you to do. You don't just automatically do that. All right. Intracranial hemorrhage. So, of course, this is bleeding in the brain, right? Most common type of birth injury. So, could be a traumatic birth, a vacuum, forceps, things like that. Something bad happened. Or it can be from trauma or anoxia, lack of oxygen. So what if all of a sudden they get placental abruption, pops off the wall of the uterus, takes us a few minutes to get her to the OR and the baby out? Well, during that time, that baby could be anoxic, no oxygen, right? Okay. Occurs more often in preterm infants because remember, their lining in their brain, their vessels and stuff is just very soft. Remember, I told you, even lifting them up to change a diaper can cause a brain bleed. And can occur during precipitate. Remember, that's when labor start to finish is less than 3 hours, or a prolonged labor. And signs and symptoms just depends on how severe it is. So it can be poor suck, respiratory distress, cyanosis, twitching, forceful vomiting, high-pitched shrill cry, convulsions, the posturing, and fontanelle might be tense. Pupil of one eye constricted and the other dilated. That's a scary thing, and may occur suddenly or gradually. The problem is some of the bleeds are less horrible than others. There's this one called subgaleal that usually is deadly, and you don't know it. It's such a big bleed inside that you don't even know it's happening till the baby's in really bad shape. But those are pretty rare, thank goodness. So here's the posturing that we're talking about. See how that baby's just laying in that weird angle? And then see the hands. Remember we talked about this before, that thumb tucked under like that, a sign of central nervous system involvement. And so is posturing. It's a very scary thing to see kids, babies like that. You know that they probably have brain damage and central nervous system involvement. That's usually from anoxia, lack of oxygen, right? Okay. So TTN is what we see the most of. It's usually after, remember I told you, C-sections, the baby doesn't get the squeeze through the birth canal to get rid of all those fluids. So it stays in their lungs. and it can cause the baby to have transient, come and go, right? Tachypnea, so high respiratory rate in the newborn. Juicy baby. Yes, good, Maritza. I love it. Never forget it. Yep, those are my juicy babies. You got it. And while we're speaking of juicy babies, remember, I'm going to remind you for a reason. Remember, if you see a bunch of stuff, you want to use the bulb suction, right? But always mouth first. Remember, you want to get it out of the mouth. So when you do the nose, they don't take a breath and breathe all that in to their lungs, exactly to prevent aspiration. So, because there's a couple questions on the quiz, you guys, that are a little bit from review, but are pretty common sense that you should remember. Okay. So I'm trying to review for you. Okay. So babies are usually just very tachypnic. They just are really breathing fast. Okay. Can have the respiratory distress stuff, grunting, flaring, retracting. Always remember when we're talking about respiratory distress, we're always grunting, flaring, retracting, GFR, 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 GFR. Those are the things we're looking for. So retractions, grunting, nasal flaring. Okay. So flaring is the F. They can be mildly cyanotic, remember, tongue and gums, and often referred to as wet lung or respiratory distress syndrome type 2. You don't have to remember the types, but just FYI. And usually resolves in a couple of days. Literally, they are working hard to get rid of all that fluid out of their system. So treatment is supportive. Sometimes they need oxygen, sometimes they don't. Sometimes we just have to really be careful when we feed them, how we feed them. Don't stress them out, conserve their energy, keep them warm. Some babies do fine. Some babies literally get shipped out. Remember, I told you if it sits in there too long, that fluid, moist, warm, they can get pneumonia. Okay, then we get into this neonatal substance withdrawal. So this is, and I would know NAS inside and out if I were you guys. So NAS is neonatal abstinence syndrome, and we're going to talk about it. But what we're talking about is babies withdrawing from some substance mother took during pregnancy. Okay. So things like alcohol, tobacco, or drugs. Substance withdrawal in the newborn occurs when the parent uses drugs that have addictive properties during pregnancy. So includes illegal drugs, prescription drugs, alcohol, and tobacco. So the syndrome is knowing that any of those products can cause anomalies, defects in the baby, but we can't always anticipate what's going to be wrong because it all depends on specific drug. When did they use it? How much did they use it? Was it daily? Was it 10 times a day? Was it only in the first part of pregnancy? How much? And infant oftentimes will have long-term developmental issues, pulmonary, neurological deficits. The worst drug for a baby's brain is methamphetamines because it's made of not natural things. Best drug, pure heroin, because it doesn't have junk in it. Worst is methamphetamines. Methamphetamines literally can make the synapse, where brain cells are supposed to synapse, right, to the next, the neurons and the synapse, it literally can't synapse. So that's why you get kids with ADD and stuff like that, because they literally don't have it in their brain to be able to control it. It's just, that's what's so sad. Anyways, tobacco is often thought of as benign by a lot of people, unfortunately. I think it's getting more and more where people know that it's not good during pregnancy, but it can cause prematurity. You got to know it can cause low birth weight. Remember, I talked about that nurse I worked with that said, yeah, she didn't want a big baby. That's why she continued to smoke. Unbelievable. Remember, smoking, the reason why it causes low birth weight babies is because they aren't getting the nutrients and oxygen they need to grow. So that's such horrible thinking. So dumb, right? Exactly. And they have increased, they're the highest risk for SIDS, sudden infant death, is women who smoked in pregnancy for the baby. Okay, so the things you've got to know what to watch for when a baby is withdrawing. So that was one question on the ATI testing last week.
It was one of the like the ATI, I don't know, I think it was capstone or something.
Okay, good.
Yeah, one of them was that smoking increased the chances of them getting the SIDS, or what was it? The
yes, SIDS, exactly. Crib death, SIDS, exactly. Oh, interesting. Well, good. I'm glad you guys are getting exposure to all that, because good. Interesting. I'm glad to hear that. Okay, so signs and symptoms, body tremors, they're very irritable, you guys. These babies they are miserable little souls. It breaks your heart when they're truly having withdrawals. But that's the primary sign. They persistent shrill cry, wakefulness. They're very orally fixated. They're always wanting something in or near their mouth. They literally get red raw from doing that. They get diarrhea, which can cause major diaper rashes, poor feeding, sneezing, yawning. These are literally things there's this, it's called the Finnegan scoring sheet. So say you have a mom who delivers and she has said, I did methamphetamines throughout my whole pregnancy. So we know we're going to have a baby going through withdrawal. So there's a scoring sheet that you do every 3 hours. And one of them is how many times has the baby yawned in that amount of time? How many times has the baby sneezed? Things like that. And that's how you score. And when the score starts getting, I think it's above 10 or 11, something like that, is when you start worrying about the baby having seizures and things from the withdrawal. And so that's usually when they get shipped out to another hospital and put on IVs and phenobarb and things like that. And do you know that a baby can spend up to 3 months in a hospital just withdrawing from those drugs? Very sad. Yeah, I'm pretty sure it's called the Finnegan score. Am I right? Has anybody looked it up? I'm pretty sure that's what it's called, Finnegan. If anybody has a second, I don't want to tell you wrong. I thought it was called Finnegan scoring. Yes. Okay, good. There's so many different score sheets we have, huh, you guys? You're welcome. Okay, so how do we test for it? So if the mom denies, but this baby is withdrawing, it's pretty darn obvious. What we can do is you collect all the meconium from birth until it starts getting to a transitional stool, and you put it in a cup. You put it all in a cup, and you send it to the lab for testing. And that shows several months. We talked about it in class. Brittany had asked that question, which is very interesting. And then the other test that's even more efficient, because it shows the whole pregnancy, is a piece of the umbilical cord we send to the lab, and they do drug testing. And then we get the results and know how to deal with it if parents won't fess up. And I usually say to them, I am not making any judgment call on you. I am not in any way. I just want to know how to take care of your baby and keep your baby comfortable. That's why I would really appreciate honesty right now, is so I know how to take care of your baby. Anyways, things that really help these babies are real tight swaddling, wrapped up really tight, quiet environment. And of course, you've got to always observe for seizures. Remember, newborn seizures are atypical. They aren't like adult seizures. I just told you the hands, rhythmic things, the feet, cycling, eyes, just things that are very rhythmic is what you watch for in a newborn. Okay. And again, sometimes they give morphine, phenobarb, just depends. All right, fetal alcohol syndrome. Super sad. These poor kids, they don't have a chance. So, the fetus of a woman who takes drugs or drinks alcohol is exposed to higher levels of the substance for a longer time because the substances become concentrated in the amniotic fluid and the fetus ingests the fluid. So, let's think about that for a minute. What does this mean? So, the fetus is floating around in its amniotic fluid. Well, amniotic fluid is mostly fetal urine. The baby swallows and pees, swallows and pees. So that amniotic fluid, a lot of it is going through that baby's system over and over. So that's why they're saying they get more concentrated of it. It's not just mom went on a binge, breastfed, baby drank it once. No, the baby's drinking it over and over again. That's why it's so dangerous. So, alcohol is the most commonly abused substance by women of childbearing age. And a lot of it's because they're out having fun partying, not knowing they're pregnant. And can cause growth restriction, intellectual impairment, facial abnormalities, can cause sleep disturbances. You guys got to remember these, with poor wake sleep patterns. And look at this poor little baby. Look at this face. So you can see the characteristics, the small eye opening, the smooth philtrum right here, the very thin upper lip. There's other signs too, but just that's the basics. So sad. Okay. So, infant of a diabetic mom. We've talked about this before, but we got to talk about it a little bit more again. Remember, these babies get large amounts of glucose. So, mom eats her food, right? And the sugar goes through the placenta to the baby. So, all this blood that's coming through is sugary and sticky. And that's oftentimes, just as a review, I know we've talked about it already, but why babies can have die in utero, things like that, is because that blood is just too thick to circulate the right amount of oxygen to that fetus. So what happens is that causes fetus to become hyperglycemic, right? Too much sugar. Then the fetal pancreas produces large amounts of fetal insulin to try to cover all this sugar, right? Then it leads to hyperinsulinism, along with excess production of protein and fatty acids. So this is why we get these chubby babies. So often results in, remember, LGA, large for gestational age. Okay, so babies weighing more than 9 pounds. Macrosomia, so macro, large, right? So, and remember, see how this baby has a lot of its pudge up top, the cheeks and all that. Remember the shoulders getting stuck? So, how you know if a baby has low blood sugar? First of all, we should be on high alert. It's protocol when mom is a diabetic, diagnosed diabetic. Baby goes on a blood sugar protocol, period. But any baby that you notice starts getting jittery, you need to think blood sugar. and you need to do a heel stick. It's always a heel stick. Sometimes the lab will come and draw glucose for us if we need it, but almost always, the nurses get heel sticks on babies and then take it from there, depending on what the results are. So they get jittery, tremors, then they can get lethargic, weak cry. So check newborn blood sugar heel stick if symptomatic. So if you see any of that, it's literally usually in standing orders for the pediatricians leave for us that if jittery, check a blood sugar. But especially if it's a known diabetic mother, we have to watch those kids super close. Because again, remember, once the baby's born, it's getting cut off from all that sugar that it's used to getting. But it's still producing these massive amounts of insulin because it's used to having to cover all that sugar. So their blood sugar can just take a nosedive so fast. So those babies have to be watched very closely because, again, oh, no worries. Thanks, Jennifer. Again, sugar feeds a baby's brain. Their brains need sugar. Okay. All right. So that's the last slide. Any questions on any of that? Okay, so let's go over what our plan is. See if I grab the right papers. And of course, I didn't. Just a second. I have two different syllabuses because I made that separate one, remember? Let's see. Okay. And the more I organize, the more I can't ever find anything, of course. Let's see. Here, let's take a 5-minute break. Let's come back at 5 after 11, and then we'll go over everything, and then hopefully we'll let you go for the day. Just let me get organized, okay? So 5
Okay.
after. Okay.